Thanks so much, Drew, for that kind introduction and for the perseverance over the last 3 years in planning this. And it's really great to be back. So thank you all for your time this morning. So I have no financial relationships with the industry to disclose. I do have research support, as Drew mentioned, and then also have volunteer board positions in pediatric orthopedic organizations. So due to the nature of this grand rounds, before just diving straight into Perthes disease, and as we are heading into Inman and Abbott conference, I want to spend a few minutes introducing myself, the institution where I practice, and then also some reflections on time here as a resident. So to many of you, Gillette Children's is probably not a familiar name. We were founded in 1897 by an orthopedic surgeon, not by the razor company. And this was a hospital dedicated to children with disabilities. And actually, it was the nation's first hospital dedicated to children with disabilities. And this orthopedic surgeon actually co-founded it with a college student from Carleton College who had scoliosis and thought that there needed to be better care for patients with orthopedic conditions. And so we did just celebrate our 125th year anniversary. We have a very strong spine history. John Moe started the scoliosis service at Gillette in 1948. And then as we discussed this morning, Gillette has a longstanding history with motion analysis. So my senior partner and mentor, Steve Koop, started the gait lab at Gillette in the late 1980s. And then also we had the expertise of Jim Gage, who really was a gait lab pioneer. And we were one of the first institutions in the nation to look at gait using computers. And now we're one of the busiest gait labs in the world, evaluating over 500 patients a year. And the gait lab is one of the things that Gillette is really known for, especially in pediatrics, orthopedic circles. And although our hospital mission really focuses on childhood onset disabilities and neuromuscular conditions, we really see basically the full breadth of pediatric orthopedic conditions. And then we're somewhat unique in that we follow our patients into adulthood. A lot of institutions stop following their patients at 18 or 25 and just kind of say, good luck. But we are able to follow in a multidisciplinary fashion our patients into adulthood. So I have a range of patients from newborns to patients in their 80s. And over the last 125 years, we have grown. We continue to be really orthopedically focused and focus on patients with short-term and long-term disabilities, but we've become really multidisciplinary. And specifically, we include the disciplines that are relevant to our patients with these childhood onset conditions. We are not a full-service children's hospital. And then also our orthopedic group has really grown. We have 15 full-time orthopedic and spine surgeons, and we are the biggest pediatric orthopedic group in the region. Pictured here is my co-resident, Tanner Guillaume, who is a pediatric spine surgeon at Gillette. We were in the same class and now work side by side at Gillette. And then we also have a number of sub-specialty experts that work with us part-time, like Anne Van Heest, who's known for her congenital upper extremity work, also her education work, and she's our incoming AOA president. And also Mark Dahl, who is known for his limb deformity expertise and really has been a pioneer in the field. We, like you, are very dedicated to education. We are an independent institution, but many of us are affiliated with the University of Minnesota, and we are the pediatric orthopedic training site for the University of Minnesota. And then we also train residents from the Mayo Clinic and Henry Ford for part of their peds ortho experience. So we are located in St. Paul, Minnesota, which is here, for those of you who find the middle of the country a little bit fuzzy. But we do have a strong relationship historically with UCSF. So Dr. Bradford and Dr. Hu moved to UCSF from the Twin Cities, where they had been, I guess, doing spine. Bradford had a spine practice in the Twin Cities, and Dr. Hu, I believe, was his fellow or trainee, and then they came to UCSF. We have a number of UCSF graduates practicing the Twin Cities, and this is not an all-inclusive list, but just a sampling of UCSF grads. We have 2 University of Minnesota residents who just matched here for fellowship. And starting, I believe, either summer or fall, Michael Chow will be starting here, and he's one of our University of Minnesota grads. And then I saw that the avid visiting professor is Andy Schmidt, who works at Hennepin Healthcare, which is in Minneapolis. It's actually where my husband works. So I just want to spend a few minutes reflecting on residency, and I think it's important to kind of set the chronological stage. And so I first visited UCSF as a sub-I in 2004, and then graduated residency, as Drew mentioned, in 2010. So what was happening in the world? Well, SARS was coming to a close in 2004, and this was our first introduction to widespread masking. Schwarzenegger was governor. Bush had just been elected for a second term, and we were still cheering for Lance Armstrong. Facebook became available to the public somewhere in 2006. And in 2007, that summer, is when the iPhone came out, which meant that for about half of residency, we were using BlackBerries. Just going to pause for just a second. And then Obama was sworn in January of 2009, towards the end of my residency. So where were we as a department? So when I came as a medical student, a certain Dr. Hubert Kim was the longstanding residency director, and Dr. Strauss, now Schroeder, was an intern. Dr. Vale became chair, I believe, in January of 2007 during my R2 year. And then around 2009 is when the Orthopedic Institute opened, and also when Dr. Feely joined UCSF fresh out of training. So I do want to make a nod to my class, and you might see some familiar faces. So we have Dr. Eric Hansen. And Hansen started with us until he had his research year. And then a certain Dr. Alexis Dang graduated with us after his research year. We have Mike Kelly, who's now a pediatric spine surgeon at Rady Children's in San Diego. We have Cameron Sadeghi, who's a trauma surgeon at Kaiser San Diego. We have a partner of mine at Gillette, who's also a pediatric spine surgeon, also Tenor Guillaume, meaning that Mike, Tenor, and I all can kind of see each other at annual meetings like POSNA. And then Mike Laidlaw, who after finishing out his time with the Air Force, is now a sports surgeon in Ohio. So in preparing to speak for you today, I've spent a lot of time reflecting on my time here as a resident. And while you think of residency as a time to learn our field and learn our surgical skills, it's much bigger than that. Our field is going to change. These skills, or at least the specific techniques, are probably going to change. The implants will change. But really, in residency, you're also learning how to be a doctor, you're learning how to be a professional, you're learning how to be a citizen of our field, and also you're learning how to be an educator. So in reflecting on this, I wanted to share 5 life lessons that I took away from residency that are kind of non-technical, but just sort of bigger life lessons. And so one is of working in a team and working in a dyad, especially now that I work with residencies that have different types of infrastructure. I have a real appreciation for the team structure that we had here in training. And I just, when you think back to those years at the county, and each year you had kind of graduated responsibility, you learned how to distribute the work amongst a team. You got to see lots of different leadership styles, and you actually got to learn how to be a leader yourself and try out some different kind of leadership styles yourself. I think that is really important as, in your own professional development. And so I reflect on this frequently, and I wish all residency programs could have a team structure like this. Don't worry, Rosa, you're up. So then we also learned how to function as a dyad. I mean, when I think back of all those pairings that I had as a resident, whether on arthroplasty, spine, at the VA, those are all meaningful relationships to me, but also I think that it's important to know how to function as a dyad. And there's a lot of kind of leadership in medicine and healthcare that uses that dyad structure. Oftentimes it's like a physician leader with an administrative partner. But I think it's important to know how to function as a dyad, kind of clinically and administratively. And I think that, sharing the responsibility, sharing the opportunities, having good communication, these are all things that we learn as we interact in teams and dyads. You guys get appropriate screenshots there? I saw. So also to all the educators in the room, which is really everyone, I want to emphasize that small teaching moments matter. It's not all about kind of big lectures like this, but it can come down to comments in the hall or conversations in the elevator or just even brief comments in conference. And I just want to say to those of you in the room that are kind of thinking about if these moments mean anything. I mean, I think they stick with you. You find yourself repeating them, reflecting on them, appreciating them, and then passing them on to others. So just to give like a few examples of those, I remember being in conference and Dr. Vale saying, the only thing you can control in life is your behavior. I think about this all the time. I've used that in coaching trainees and younger colleagues as recently as about a week ago. And so I think that's really important. But it was one sentence, and here we are 13 years later, and I'm still using it. Or Dr. Hubert Kim sitting down with me at the beach chalet over beers after the VA and sketching out a research study for me on a napkin. I remember Dr. Latanza standing up for me as a med student. I was about to give my sub-I rotation and conference was running late, and I was asked if I could cut it short. And she demanded that I got the same time as everyone else. And I saw that, students and trainees are valued. And then also Dr. Ma emphasizing that even if you have just like a few minutes with the patients, it's important to sit down. It's also important to run the list at the end of the day. And Tenor and I both still run the list at the end of the day. But this message is not just for the attendings in the room. This is also for the residents. As residents, you have so many opportunities to teach each other and to be near peer mentors. And I don't want this to be under-recognized. You play a huge part in teaching each other. Also, it was wonderful to be able to train in a program that believes and practices with thinking that women are an essential part of orthopedics. I think there's so many places in the nation where they're just looking to kind of like check the woman box. And residency is hard enough without having to prove your gender every step of the way, right? And so to be someplace where you're not like the woman orthopedist, instead you're an orthopedic surgeon who happens to be a woman. I mean, that makes a big difference. And so then also I'm honored to be part of a department that similarly champions women. We actually just graduated our 50th and 51st female resident, which nicely correlated with the 50th anniversary of Title IX. And also pediatric orthopedics really celebrates women in the field as well. So balance, hot topic. I know it's being discussed upcoming at Inman Abbott by Dr. Feely. I think there's no right answer, and we all do it differently. But as you're thinking about balancing your clinical care, your research, education, service, and life outside, you have great mentors in this room. So, ask them how they balance and really just look to the people in the room that are making it happen and doing it with style. And lastly, it is important to have fun, okay? So there are many weeks, actually most weeks, you are spending more time with the people at work than you are with the people at home, okay? So it is very important to enjoy the people that are around you and actually to try to even be enjoyable yourself. But I think it's, even just small moments of work, of having fun, whether you also find time, near work or right outside of work, whether it's like going out after anatomy sessions or going to the ramp, if it still exists, at the county during lunch. Finding other opportunities to go out. This was my class at the academy meeting when we were 4s. And then also celebrating the outside world, outside the bounds of the hospital. And this is when Dr. Diab went snowshoeing with us, graduating. And after giving that grand rounds, where I had really immersed myself in the literature, I then moved to Dallas, as Drew mentioned, for my fellowship at Texas Scottish Rite. And there was Perthes giant Tony Herring, who had been the longstanding fellowship director and chief of staff. And also, it just so happened that Harry Kim had just moved from Tampa to Dallas to continue his Perthes practice and his Perthes research. So in Dallas, I was able to work with Dr. Herring and Dr. Kim side by side in Perthes Clinic, and they had fantastic debates arguing about the management of disease. And then because I had immersed myself in the literature for my resident grand rounds, I could kind of speak the Perthes language. And because Dr. Kim was new to Scottish Rite, he wasn't really assigned a fellow. And so then therefore I got to join him on most of his Perthes cases, including the first ever interosseous injection of bisphosphonates in a child, not piglet. So shortly after I finished fellowship and started at Gillette, Harry Kim started the International Perthes Study Group. And this, in some ways, was kind of an international reboot of what Dr. Herring had done, but this was on a more global scale. I was brand new to practice, so I was totally honored to be invited. And so here we are at the first International Perthes Study Group meeting, which, again, I'm not even a full year into practice, and I'm in this room with like Perthes giants, and I took notes like I was a court reporter. I was really trying to take it all in. I didn't want to miss anything that anyone said. And then at the end of the meeting, Dr. Kim kind of sheepishly said, "I'm so excited about this meeting. I forgot to take any notes or minutes. Did anyone take any notes?" And I literally like transcribed the whole meeting. So, raised my hand, turned them into minutes. And in that way, I shortly after that became the secretary, which actually meant that I took a lot of notes, but then also let me be at these subcommittee meetings in the early stages of the Perthes study group. And I got to help with some of the study design for some of the big prospective studies that are going on today. And that was my way to kind of contribute, even though I was only like 6 months into practice and had probably only seen like one Perthes patient in my own practice. So other than that one big study that I talked about by Dr. Herring, the multicenter study, the only other big prospective multicenter study was out of Norway. And I was lucky enough about 5 years ago to be able to go on a European traveling fellowship. And one of the sites for that fellowship just happened to be in Norway. So I was able to meet some of these Perthes giants in Norway and kind of debate Perthes with them, which is one of my favorite things to do. And so here we have Terje Terjesen, who is a real giant in looking at long-term outcome studies, and Ulla Wiig, who really drove that study, and then Stefan Hunsok, who's their newer partner. And it's because of an experience like that and being able to argue Perthes, we now have these lasting collaborations. And I think I'm actually going to be helping out Stefan with the 50-year outcome study of Perthes in Norway. So in the meantime, we're developing multiple lines of research on Perthes at Gillette. And also we decided to have a dedicated Perthes clinic. And that's our little like Perthes sticker that patients can wear in the waiting room if they decide to. And part of the reason of having a dedicated Perthes clinic is so that patients and families can identify each other. This is a rare disease. It's nice to have community, and then also to have the appropriate resources available. And then the IPSG continued to grow. We've now enrolled over 1,000 patients. After taking a lot of notes as secretary, I now am on the executive committee with some of my mentors, which has been really an honor to be able to play a role in kind of the strategic planning for this group. And Gillette is now one of the top enrolling sites. And we are very excited to have a new member, Dr. Swaroop, join our Perthes club. Okay, so with that, moving on to Perthes disease itself. So as Drew mentioned, he had asked me to come speak for kind of what was going to be the 10-year anniversary or 10-year mark from my graduation. And so, my initial thought was that it would be, a 10-year update from basically my talk as a 4. We're going to instead call this like a 10-ish year update, but a little bit more like 13. But just to get a quick sense of the room, and I won't make you pass around the microphone like I did this morning, but how many of the trainees have seen a Perthes patient? Okay, so maybe half or a little bit under half. How many of you feel confident in how to treat Perthes? Okay, right answer. Okay, so just to make sure that we're all on the same page about what this is. So Perthes disease is an idiopathic avascular necrosis of the femoral head in kids. It happens in boys more often than girls, and we typically see it in ages 4 to 9, but the overall age range is broader than that. And it's known that there's a loss of blood supply to the femoral head, although we don't know why. And then there is a fairly reliable process of revascularization. You then absorb the dead bone and build new bone. But unfortunately, as it goes through all these stages, the femoral head becomes fragile and can deform, oftentimes even fairly significantly. So most of our treatment is aimed at preventing femoral head deformity, and it's thought that femoral head deformity correlates with early arthritis. So I've been told that it's really important at any talk to identify a villain early on, okay, a villain that everyone can relate to. And so what's our villain here with Perthes? And so I think that many of us might answer that it's femoral head deformity, as you see here on X-ray. And others might answer that it's the pain that these kids have, both in the acute stage and then also later on with hip dysfunction in adulthood. And still others might say it's the early onset arthritis. And this is actually a teenage patient with Perthes disease that Dr. Patrick Horst helped me with about 2 years ago. Bless you. But I would say that I think that there's another villain that really bothers me as well. And I think it's the uncertainty. It's our inability to give patients and families good answers about prognosis, etiology, and even evidence-based treatment options. And I think that this is unacceptable. And this is why I dedicate so many of my work hours and free time to thinking about this condition. So compared to so many other areas of orthopedics where we are making minor modifications on technique or tweaking implants or working on trying to make post-op recovery more efficient, for Perthes, we still have really big questions that remain unanswered. I mean, bless you, like the big questions, right? So why does it happen? How do you prevent it? Which treatment is best? Who benefits of treatment? And even do our treatments work? So why don't we have more answers? Gotta say, it's not for a lack of trying, okay? There is an enormous amount of literature on Perthes disease, and this is a quote from Mercer Ring 20 years ago, basically talking about how much literature there is on Perthes disease. And one of the reasons we don't have better answers is because it's really challenging to study a pediatric rare disease. So oftentimes at each center, you only have a few cases, right? So historically, studies would be these small retrospective studies that were from a single center. And then to be able to have adequate numbers for data analysis, they would group together patients that were heterogeneous, whether in age or severity or stage, and they would even sometimes group treatment options and oftentimes lack the necessary controls. So not surprisingly, these smaller studies with more limited methodology led to kind of conflicting results. And this oftentimes just kind of further confused the picture. So even as we think about better study methodology, surgeon bias can really limit study design as we're planning prospective studies. I don't know if you guys have noticed, but orthopedic surgeons tend to be somewhat opinionated about their treatment regimens, and especially if there isn't a gold standard or there isn't really strong evidence-based medicine to prove what you should be doing. People are really wedded to their treatment plan, saying like, this is what's right. So when you try to get people together for a study, it's really difficult to get people to agree on treatment arms. And then it's even harder to get them to agree to, for instance, like randomization, right? So that also we're really limited in how we can study Perthes disease because these are healthy children. We're trying to preserve the femoral head, right? So you don't really have a lot of histologic samples that you can look at to further understand the pathophysiology. So my goal today is to look at what we've learned in the last decade-ish or so about Perthes and to tell you where I think that we're headed. And I'd love to talk about Perthes all week, but I'll try to focus this here to 5 areas or windows into Perthes. And I think that many of these areas also are relevant to other areas of orthopedics. So let's start out with etiology. This is the first question I get from families, like, why does my kid have this? And there's been an enormous amount of work into the etiology of Perthes disease. And while it's clear that there's a loss of blood supply to the femoral head, beyond that, we really aren't sure what causes it. And there have been multiple lines of inquiry into the etiology, but most of us now believe that this is probably multifactorial. So many of us do think that environment probably plays a role. And it's noted that the highest incidence of Perthes disease is in Northern Europe, which has prompted questions about correlation with Perthes disease and latitude. And in a large epidemiological study, they found that every 10 degrees farther north from the equator, you have an increase in Perthes disease for 50%. And this is an association that's shared with other diseases such as multiple sclerosis and also osteoporosis. So it makes you wonder, is there like an infectious agent or is this vitamin D related? Also, there have been longstanding studies showing that there's an association with socioeconomic deprivation. And initially, these studies were back in the 80s. Things have changed, right? Maybe it's no longer correlates, but actually in the UK, it's still been shown that socioeconomic deprivation does correlate with incidence of Perthes disease. And so the most deprived quintiles in the UK have 3 times the incidence versus the most affluent quintile in the UK. And there's thought that smoking may play a role. So there have been longstanding studies showing that secondhand smoke exposure in childhood has a higher incidence of Perthes disease, but it's also been shown that the children that are exposed to tobacco smoke during pregnancy are at risk, as well as children who have a wood-burning stove in their home. So it's not just tobacco smoke. So in addition to environment, many of us think that they're mechanical factors. Okay. For those of us that treat Perthes disease, I think that we all know that like this is the Perthes kid, right? This is the kid that you're saying no running or jumping for a year or two. Okay, so it's been known that there's a high percentage of children with Perthes disease that have ADHD or a motor expressive personality. And it's even been shown out of a large Swedish registry study that Perthes disease, or kids with Perthes disease, are more likely to have lower extremity injuries. They're just really active. So could this be due to repetitive small trauma? Well, maybe. There are many studies on whether this is due to a clotting problem or coagulopathy. And I'm just going to spare the details because for every study that says yes, there's a study that says no. Okay. So it remains inconclusive. But my own thinking about this is that if this is due to a coagulopathy, why are we just seeing it impact the hip? Families always ask too, is this genetic? Right? Maybe they have a family member that has it, or maybe they heard about a case that ran in families in the literature. And so there are cases reported of Perthes running in families, but there also has been a somewhat recent twin study that looked at identical twin pairs where one had it, and of those 10, the other one did not. So this argues pretty strongly that there is not a strong inherited component. And the reason that we see this familiar clustering is probably because they're in the same environment. So although this is not thought to be strongly genetic, there is kind of a Perthes phenotype, okay? Kids tend to be skeletally immature. They tend to be a little bit shorter and actually, interestingly, have smaller hands and feet. And then also in a more recent study was found that they even have smaller blood vessels, even when adjusting for height. And the blood vessels even have some level of dysfunction. So it's thought that this may play a role. But then where does this leave us? So you have maybe a combination of repetitive micro trauma in kids that are small for size and have even smaller blood vessels, and they're exposed to smoke and they live in the north. I mean, it's really thought to be multifactorial. We have a lot of room to move here, but I think especially, for instance, this study is looking at like abnormal vasculature could lead to further study or even long-term impacts that you might see due to vascular dysfunction in kids with Perthes disease. So moving on to imaging, another challenge that we have with Perthes disease is that when this healthy kid comes into your clinic, you don't know what this hip is going to look like, right? It's even hard to convince parents that this is much of a problem because it's so subtle on x-ray. And so, will it turn into this hip, which is considered a pretty good outcome, right? This is a pretty spherical femoral head and a pretty congruent joint. Will it look like this hip, which is pretty ovoid and that acetabulum is pretty dysplastic? Or will it look like this hip, which is clearly saddle-shaped and hinging and kind of a disaster? So the gold standard of diagnosis and treatment has been the use of plain radiographs. Okay, and we still use them. And in fact, the first descriptions of Perthes disease actually correlated with the emergence of this technology. But a real problem that we have with radiographs is that the changes you see on X-ray really lag behind the physiologic process that's happening. So we've really turned to MRI for further answers. So we've been using MRI for decades now, right? And all sorts of field aspects of orthopedics to get better sense of, three-dimensional shape, soft tissues, cartilage. But in the last 10 to 15 years for Perthes disease, we've really been leaning on perfusion MRI, okay? And so do you all know what perfusion MRI is? Okay. Thank you. Okay, so perfusion MRI is basically you take a standard series of MRI images, and then you give contrast or gadolinium, and then you run that same series, okay? And then the computer digitally overlays these images and then subtracts them. So normal perfusion on a perfusion scan for bone appears kind of like medium to dark gray, okay? But areas that are hypoperfused, areas that have no GAD, appear very dark, as you see here with this little yellow asterisk. So I think the study from 2013 that nicely demonstrates some of the imaging clarity that perfusion MRI provides in the early stages of Perthes disease is this one. And so this was 3 pediatric radiologists and 1 pediatric orthopedic surgeon who all looked at kind of standard T1 weighted pre-contrast images of patients with early Perthes disease and then looked at perfusion scans, okay? And so, for instance, we're going to do this kind of as a group exercise. So this is an 11-year-old who had 2 months of pain, so stage 1 Perthes disease. And this is the T1 coronal fast spin echo image. So how much of the head do you think is involved? How much looks hypovascular? Like 10%, 50%, 90%? Just shout out some numbers. Great. So we've got 10 to 70, right? And pretty representative of what they thought as well, right? Okay, but here's the perfusion scan. Now what do you think? Right. They agree with you, right? This is much more involved than what you see on that T1 weighted image. And just to give you one more example, here's one that looks pretty darn mild on that T1 weighted image. And here it is on perfusion scan. So it, in general, is noted, just as we noted here, that the area of involvement was more clearly visible and there's higher inter-observer liability, and thought that the perfusion MRI just gives us more information about how involved this hip is, especially in the early stages of disease. So then you want to ask, well, does it really mean anything clinically? Well, there have been some studies to show that there is some correlation with radiographic outcome at 2 years and also with the development of lateral pillar classification. It's maybe not quite as strong as we'd like it to be, but there is thought to be some correlation. And it's thought that if you have a child with Perthes that comes in and they have good perfusion on MRI, that is thought to be a very good prognostic factor. So the perfusion MRI has not only been useful in the early stages of disease, but also has been used to give us information on the revascularization process. And this study of serial perfusion MRIs have shown us that the femoral head pretty reliably reperfuses in this like posterior horseshoe fashion, where the center of the head and the anterior aspect of the head are the last to revascularize. And this actually confirms scintigraphic studies back from the 90s about that pattern and also what's being seen in the piglet. Then if we're thinking about doing these perfusion scans in kids, and especially if we're thinking about doing serial perfusion scans, we need to know, is GAD safe? And I think as many of you know, it's been shown that gadolinium does deposit in the brain, and it's been shown in patients that have multiple GAD doses that there is brain deposition. And it's actually more recently been shown that there's bone deposition that's evident 5 years after even just a single dose. But the clinical implications of this remain unknown. So I think it's important to use it when you really think it's going to inform your treatment. The IPSG has looked at perfusion scans and if there have been any serious adverse events, and we have found none, both in a study that was published in 2014, as well as we just recently looked at our data, and it's unpublished, but we still had no adverse events from perfusion MRI. But we do recommend that you typically ask patients at least if they have a history of renal disease. So where are we headed? So Gillette, we have great fortune of being able to collaborate with the University of Minnesota and their Center of Magnetic Resonance Research, the CMRR. And these are, and also with experts in the University of Minnesota Veterinary School. And they're really doing cutting edge, groundbreaking work in the imaging of cartilage and bone. And so they have multiple 3T scanners that they use for clinical use, but they also have 9T and 13T scanners that they use for research purposes. And this group has been very productive using animal models of OCD as well as human cadaveric models. And they've shown that they can use quantitative non-contrast, so no gadolinium MRI, to show ischemic change as seen here, and also to give CT-like imaging of bone. This is MRI. And they've also developed a susceptibility-weighted MRI technique that can demonstrate the vascular architecture, in the epiphyseal cartilage of the distal femur. And this has helped them with thinking about the underlying etiology of OCD. Again, this is no contrast. So when Harry Kim was in town for visiting professorship, I was able to introduce him to this team at the University of Minnesota. And it was kind of like a collaboration that was meant to be with his piglet model and their imaging techniques. And so with that collaboration, they've shown that quantitative MRI techniques, again, no GAD, are sensitive enough to show ischemic change at 48 hours in the piglet model, which is those top images, and also can show signs of repair at 4 weeks post-op. And using these techniques, you can see that the cartilage in the AVN model is thicker, just as we see in patients. And then you can also see the early formation of these vascular channels, and you can see that they're kind of densely in clusters here as that head is starting to revascularize even 4 weeks out from AVN. So our ongoing imaging goals are to continue to refine these techniques so that we can use them with patients and ideally be GAD-free and have the information that we need. And also, we'd really like to have shorter scan times to avoid sedation and make imaging, more accessible to younger patients. This is kind of part of our team here that just received R01 funding under the leadership of our MRI physicist Casey Johnson to further look at early detection of femoral head AVN with a specific aim looking at patients with Perthes disease. We're hoping that if we can learn more through imaging, and especially about the repair process, this can really inform treatment. So moving on to clinical studies. So in this drawing, it says no running, no jumping, and that it really is what we tell patients for a year or two. But are we really helping them? What do we know? So as I mentioned before, there are two big prospective cohort studies that have looked at the outcome of children with Perthes disease, the one from Hearing and the one from Legg in Norway. And to really kind of simplify these studies, kind of the big takeaways were for patients that have onset less than 6 years, that really probably no surgery is needed for most of them. Most do well, not all, most. For patients presenting between the ages of 8 to 11, some patients probably benefit from containment surgery. And so that's usually either a femoral osteotomy or a pelvic osteotomy. And then for 6 and 7-year-olds, which is actually a pretty frequent patient group in the realm of Perthes disease, and this is one that we're really conflicted on. Of course, these two studies had conflicting results. One said no difference, surgery versus no surgery, so probably don't do surgery. And the other said better with surgery. But I would say that both studies came away with the finding that bracing did not seem to have a significant benefit over other non-operative measures. So of course, in typical Perthes fashion, you then have a really promising study coming out of a single center, although it was retrospective, looking at a very aggressive containment bracing treatment regimen, and they had better results, even with the more involved hips, than they did in either of the other groups. But this brace is used until kids start to reossify, so oftentimes most of 2 years. So over the last 15 years, it's been noted that patients who go through the resorption stage, which we call fragmentation, if they can go through that stage more quickly, they're thought to have a milder course, because it's thought that the femoral head has a shorter period of fragility. And so if you can move them through that more quickly, they're less likely to have femoral head deformation. And so there have been studies that have suggested that an early osteotomy in the early phases of disease decrease that period of fragmentation. But unfortunately, in these studies, we kind of lack the necessary controls, but I think that there'll be future work in this realm. So one of the most controversial points of Perthes is how long do you keep patients non-weight bearing? And this is a very small single center study that showed better radiographic outcome with prolonged non-weight bearing, oftentimes not only greater than 6 months, but also oftentimes for these patients greater than a year. But this is only 11 patients, and I'll touch more on this subject tomorrow, so to be continued. Then also with all of our emphasis on femoral head shape, I think we need to ask, does it really matter? And so this was a callback study from the initial Hearing study where they brought back patients an average of 20 years out from their Perthes management. And, historically we thought round head, good outcome, ovoid head, fair outcome, flat head, poor outcome. But actually, this study showed that if you have a femoral head that is anything but spherical, you're very high risk for early onset arthritis. Now, if you think about this, these kids are, say, 6, 7, 8, 9 at the time of their Perthes disease, and this is 20 years out, which means that they're your age and they have arthritis. So since the Hearing and Legg studies, this is the biggest prospective study to come out. Okay, and this is a surveillance study. This did not have specific treatment arms, but this is a study out of the UK where for 18 months, they were able to get almost all the pediatric centers to enroll their Perthes patients that were diagnosed over 18 months, and they followed them for 2 years. And so again, surgeons were not committing to treatment arms, but looking back at what the surgeons did, they found that what really seemed to decide treatment was joint stiffness and older age. And so for the under 6ers, most were treated non-op. And for the older kids, especially the stiff ones, a lot of them had containment surgery. But despite what the surgeons were using to guide their treatment, actually it was found that female sex, older age, and greater head collapse really were correlated with outcome. And interestingly, surgical treatment did not correlate with radiographic outcome, nor did stiffness. So what now? I've already mentioned the IPSG. We've been working to answer some of these questions since 2012, and we're enrolling patients in prospective multi-center studies. We're looking at operative options, non-operative treatment arms. We're grouping patients in smaller age groups to try to answer questions more definitively, because a 5-year-old is not the same as an 11-year-old with this disease. And we're looking at radiographic and functional outcomes. But we are not participating in anything randomized yet. So if interested in looking at someone who's changing research culture, Dan Perry from Oxford is really changing the culture of research in pediatric orthopedics in the UK. So using a combination of their centralized health system and also significant funding from the NIHR, which is the UK's version of the NIH, he has been moving along in a stepwise fashion to get cultural buy-in and infrastructure for RCTs. So we started out with buccal fractures. We started out with something that people don't really care that much about, and built the infrastructure that way. And that study actually was just published in The Lancet last year. Okay. And then he's moved on to displaced discoideus fractures and medial epicondyle fractures, and just again building. And now he has funding from the NHR for a randomized control trial for Perthes, so op versus non-op. And he's been working closely with Adam Galloway, who is pictured here, who's a physical therapist and just got his PhD. And Adam Galloway is working on developing that non-operative arm for an RCT on Perthes disease. And they are generously collaborating with us in the IPSG and sharing their methodology, their infrastructure, their techniques, and hopefully we can learn from them. That's us at POSNA a week ago. So Perthes patients used to be admitted to the hospital for a year or two for their treatment. And I know that seems kind of cruel, but really, is it all that different than us keeping them prolonged non-weight bearing or in a brace for 1 to 2 years? And nearly all Perthes research to date has been focused on radiographic outcomes. But especially if we're not really changing the radiographic outcome potentially with our treatment, maybe we should really start asking the patient how they're doing, both long-term and also short-term during these different treatments. So this is a qualitative study where they interviewed parents and children with Perthes disease. And they found that it's not only the child with Perthes disease that's impacted by this condition, but also siblings, also the parents. Families have to change their schedule, modify their life. I mean, imagine if you have a sibling that's in that brace and can't weight bear and is in a wheelchair that's this wide, it makes it a lot harder to even go to the grocery store, right? And so parents feel powerless in the management of this disease, and also they feel frustrated with limited medical understanding. Yes. And so this is a British surveillance study, but they looked at quality of life measures using specifically the PEDS-QL, and they found that at diagnosis, patients had significant decreases in quality of life scores throughout multiple domains. But interestingly, at the 2-year point, they had improved quality of life scores compared to baseline, but those improved scores were about the same as what you see in patients with progressive or recurrent cancer. This has significant impact on quality of life, and not just at diagnosis, but also when they're fairly well healed. So when feeling a little bit pessimistic about Perthes, you can have a glimmer of hope that at least they'll do better someday when they get their total hip, right? So this is a study or an abstract that was just presented at POSNA by Mike Millis in the IPSG, and this was a survey of adults with Perthes disease. Over 1,000 Perthes patients responded to it, and over 250 had total hips. But interestingly, they found that although the patients that had total hips had better HUS quality of life scores than those that didn't have total hips, they still were lower scores than kind of the normative cohort. So it's actually thought that Perthes probably has a significant burden on quality of life in adults, even after they get their total hips. So where does this leave us? Well, I think that we have better buy-in now, that we need to ask patients how they're doing. We need to incorporate PROs in our studies. And we actually have a study now that can help guide what we should be asking patients about. This is a Delphi study that determined a core outcome set. And we asked, families, patients, and surgeons what they thought was important. And so this can help guide future treatment. And then one other point that I want to make in this asking patients realm is that these patients feel very isolated with this condition, right? This is a rare disease. These are healthy kids. They typically were very active, and there's nothing on the outside that shows that anything's wrong. So they can feel very isolated. So there have been big efforts, such as through the Perthes Kids Foundation, to try to find community for these kids. And they do like annual Perthes camps and webinars. And there are also other resources for parents as well. So lastly, I want to touch on medical management. And currently there's no gold standard for medical management for Perthes disease, although many of us, I think that medical management will probably be a part of the future of Perthes care. And a lot of medical management is aimed at trying to address this balance. In Perthes disease, there's all this bone resorption and the head is fragile and it's slow to start with bone formation. And so if we could alter that balance, or at least kind of like speed up that bone formation, we think that we could improve our outcomes with Perthes disease. And a lot of this relies on relies on a piglet model. And I mentioned it previously. This is what Harry Kim presented on in 2008. And what they do here is they surgically dislocate the hip. They cut the ligamentum teres. They take a big suture. They tie it around the neck. And then they reduce the hip. And that gives you a pretty reliable, like total AVN model for the piglet. And it's found that the femoral head deforms similarly to what we see in Perthes disease. And also you can see the same radiographic stages of Perthes disease in this piglet model. And it's been shown that giving bisphosphonates in this piglet model, whether systemically or interosseously, have shown kind of promising results with maintenance of femoral head shape. So Harry Kim has been very stepwise in looking at that balance and in his process of this piglet model. So that, well, if we've slowed down the osteoclast, maybe we can add some BMP to, help with that balance. And so it was found that if you add BMP, you minimize your development of femoral head deformity. You have more new bone formation, more osteoblasts, but unfortunately, you also have HO. So that is not ideal. Or what about non-weight bearing? Can we look at non-weight bearing and whether it matters in a piglet model? And so there is a piglet model of non-weight bearing, which is really an amputee model. And they did find that non-weight bearing does preserve femoral head shape, but also they found that it significantly increased bone resorption and increased the number of osteoclasts. This does not really optimize our biology. But what if you take non-weight bearing and you add in bisphosphonates or you add in BMP? Well, then you don't see as much of that bone resorption and you don't see as many osteoclasts. Or maybe we need to take a big step back. Maybe this balance is off all because of inflammation. And so children have been shown that they have prolonged synovitis in MRI and they've increased elevations of IL-6 in the synovial fluid. And we've seen promising studies of IL-6 knockout mice with a Perthes model that they have better revascularization and better bone formation. And also in the piglet model, anti-IL-6 therapy has shown decreased synovitis, decreased resorption, and better bone formation. But I'd say that, people are like, well, what's happening with the kids? Have we translated to the kids? And there's really been limited translation. It's mostly just anecdotal reports or case reports. But the most promising study was an RCT out of Australia, which randomized kids to placebo versus bisphosphonates. And they found that while there was improved range of motion and improved pain, there was no difference in femoral head sphericity at 1 or 2 years. But unfortunately, this is only an abstract presentation. We still don't have the full paper to analyze this data further. So I think that we need meaningful clinical trials that are safe, that can, build on this work. And then also there's a question of, should we have a better preclinical model? Because clearly when kids get Perthes disease, it's not because they are having their hip surgically dislocated, right? And kids come in with different disease severities. So our team is actually working on this. This came from a dinner conversation with my husband, who's an interventional cardiologist, working on a minimally invasive Perthes piglet model, where we're using intravascular embolic techniques, trying to really simulate more what we think probably happens in the patient, and also to give us a wider range of severity. So in summary, you could take away that after the last 10 years, we're still in this state, and we really don't have solid answers to our big questions, okay? But I would argue that we've advanced along the Perthes knowledge journey, and then I think we have made some real gains. Although that journey sometimes feels like this, and that's, you should actually never use like a circle or a sphere in a Perthes analogy. So really it's probably more like this. But I think that we have better tools now within those 5 realms that I discussed to study Perthes as we move ahead. So we might not have better answers, but we have better tools. And one of them is a slightly better understanding of etiology. I think definitely having improved imaging techniques will give us better understanding of this disease and hopefully make imaging more accessible to more patients. And these techniques currently are being used in other fields, or certainly will be applied to other fields. Also, I think that we culturally need to embrace better study methodology. I think that we will need RCTs, and we will need good, at least prospective multi-center studies to be able to study this meaningfully. We need to ask the patient how they're doing, especially if we're not making much difference on the x-ray. We need to make sure that their treatments are not ruining their childhoods. And then I think that we have some promising medical options, but we need to figure out safe ways to translate them, and maybe even a different model. So we have a lot left to learn. And similar to what Arthur Legg said in his initial description of Perthes disease, I hope I've piqued some of your interest in this condition. And we would definitely welcome you to the Perthes Club if you want to help us answer some of these big questions. And I'd say to the trainees in the room, keep your eye out for topics that interest you and explore them. I will openly admit that I was not oriented towards research at all, really, as a resident. I mean, that's why Hubert Kim had to sit me aside at the beach LA to get me moving on a research project. But now research is really a regular part of my clinical care and my daily work life, and oftentimes my free time as well. And then also the department, I'd really like to thank you for launching me on my orthopedic career. I'd like to thank you for your dedicated teaching and mentorship. And it's a great pleasure to be back. So thank you.
Was excellent and impressive work. And thank you so much for coming back to visit with us. And Dr. Laine will also be speaking at Inman Abbott, I think a couple talks tomorrow morning.
On Perthes.
Well. Yeah. And then I think we do have maybe a couple minutes for questions, comments.
Thank you, Jen. That was great. I try not to use superlatives, but that's the best talk I've heard for at least a year. Well done.
Thank you. And
so appreciate your reflection at the beginning. And it's just great to watch you succeed. This is a sort of mile-high view. I wouldn't apologize too much for Perthes being an orphan disease, because I sit here and think that everything you're saying applies to scoliosis. And that's a much more prevalent disease, from things like multifactorial to the debates about bracing to the brutality of the treatment. And I think when you go around, especially since you're in a position of prominence, I think you should really sort of promote the condition, not based on its frequency, but based on its lessons. And I think if people immerse themselves in this condition, they'll become better at everything we treat, because it's all the same lessons.
Absolutely.
I keep using oval. One of my pet peeves. Oval is not a correct word. It's oval.
Thank you. Yeah, I completely agree. And I think we just really need to acknowledge the impact these conditions, whether common or rare, are having on families, even just down to fractures, right? I mean, fractures have a big impact on families. I mean, as soon as put kids in spica casts, that is scarring for families.
So we'll talk about scoliosis. But imagine a teenage girl in a brace for 4 years, right? And imagine, and even in scoliosis, we talk about the marriage rate. I mean, why are we even talking about marriage as an orthopedic surgeon? But that is a window into what you're saying. It impacts their whole life.
So one of my co-fellows is now also a member of the IPSG, and he had bilateral Perthes, and he was in a brace, I think, for 2 years. And he has an interesting perspective on it, and he talks about how it changed his relationship with his parents. He lied to them consistently because he was having pain, but he knew if he was having pain, he wasn't allowed to go outside because that's what the doctor said. And so it changed his relationship with his parents. And so he now is a big believer in certainly not bracing or prolonged non-weight bearing, because he's like, give me a total hip early. Let me have my childhood back. So I think we need to ask.
That's exactly what I was going to ask about, is how do we even start to ask that question of how many years of your childhood are worth pain in adolescence, inability to participate in sports, the total hip that's not quite great when you're 30? How do you even ask that question? I mean, I like really find myself being middle of the road with Perthes, like, well, don't go on a trampoline, but I'm not going to put you in a wheelchair for 2 years, because I just can't reconcile that with myself. But I don't know, they've sort of figured out how to ask these questions, like with, on dialysis and what it means with like quality adjusted life years. But how do we do that for kid life years?
I mean, that's a really important question. And I think that, the first step is even just asking kids and families, like, what matters about their childhood, right? One of those core outcome set questions is actually sleep. I don't have a single Perthes study that looks at impact on sleep quality. But that, for those of us that are parents in the room, like, if your kid's not sleeping, that's a big deal. And so I think that we have a lot to learn.
All right. Any other comments, questions, thoughts?
Thank you all for your time. I appreciate it.
Thank you so much.
Nice to be back.